about TAVR and bicuspid aortic valve disease type 0. These are my disclosures. And this is about a 74-year-old male, diabetic, hypertensive, ischemic heart disease, post-CABG status. Investigations, the blood investigations were all normal with normal CBC, RFT, LFT, ECG, both normal PR and QRS intervals. Echo, severe concentric LVH, bicuspid aortic valve, peak versus mean of 95 by 46 millimeters of mercury, no AR, decreased LV compliance, normal biventricular systolic function, and no wall motion abnormalities. Grafts were all patent, triple vessel disease, no revascularization required. Indeed, it's an unsystolic thing. You could see the mitral valve to be closed. The right-hand image shows a bicuspid type 0 valve with probably left anteroposterior orientation of the commissures. You can clearly see two sinuses and two commissures. Now coming to the annulus, you can see that the annulus is around 27.2, 27.3 if you measure it slightly differently. LVOT is 27.8 with an area of 608, which is slightly wider than annulus. If you see the sinus of Valsalva, it's quite roomy. The mean would be around 32 to 33, while the maximum diameter is 38, and we know that the valve is going to sit across in the minor axis and a lot of space across on both the sides, and we know that the coronaries are from both the sinuses which are opposite to each other. STJ is slightly narrower, like 26.2, but remember that it's measured at 25.7 millimeters, while if you try to understand what happens at 17 millimeters, it's clearly a lot of space there. Membrane septum, there's hardly any membrane septum as I understand. LCA height is quite good. RCA height also is quite good, 23 and 17.5, so they are really high despite the patient having a triple vessel disease. Still, both the coronaries are quite high and should be okay for any valve. Now, in coplanar view, it's 24, 35. What I typically do is I would probably put a dot here, somewhere in the middle of, because it's a bicuspid, you can see probably two dots, the green one and the red one, and you put exactly one marker in the center, so that you would get the center line like this, and you can put a dot, and then if you try to put this dot in the center, you will get a plane in which both the sinuses are exposed maximum. You can see both the sinuses are farthest apart and they are exposed maximum. So probably this would be the view which is going to show you both the commissure in the front and both the sinuses maximum, and you understand it best. You can see that the calcification is heavy, and it's symmetric on both the leaflets. The aortic arc is usual. There is no acute angulation in the aortic arc, and no acute curves. Regarding the peripheral axis, you can see that the axis as such is good and is more than 6, except for the infrarenal abdominal aorta position, where it's around 5.7, and here it is around 5.3. So grossly, you could see probably this looks more narrowed, but then again, it's a soft plaque. And here, it's around 5.7, but slightly more calcified. So in general, I would probably lean more towards the right axis in general, but I knew that it might be difficult to make a final word on this CT scan. So the points to be considered in selection of the transcatheter heart valve and probably, the challenges in the procedure. We know that this patient is 75 years old, but we also know that this is a patient who basically, India is a very heterogeneous population. You are looking at a patient who is quite rich, and for sure his life expectancy is going to be similar to a Westerner. So still, the patient is 75, I would probably still think of lifetime management if there is no CKD, no CLD, lungs are good, there's no reason why he should not live for more than 10 years. So you should keep this lifetime management in your mind despite the patient being 75. Post-CABG, we know that coronaries are all grafted and it should be good with any of the valves, but by chance if a disease happens in the graft, then we should know that the native might need to be interrogated later on. It's a large annulus, so we know that hemodynamics and durability should not be much of a challenge because we are dealing with a large annulus. And of course, we know that durability part is directly related to PPM, which is directly related to the valve degeneration and the risk of revalving. Analysis 27, so it's probably we need to size this more appropriately because it's bicuspid. It's a bicuspid type 0 with anteroposterior orientation of commissures. So we need to understand that it would be difficult to cross with wire, balloon, and THV because the wire and everything has to transect the right cusp and then enter into the orifice. It's a short membranous septum, likely for conduction disturbances, need for pacemaker management, again concern of lifetime management, and challenging peripheral access, so we need to understand what would be the best sort of system which would go through this. Regarding the anatomical challenges, I would say it's bicuspid type 0, short membranous septum, and challenging access, which would need some decisions during the procedural planning and execution. Thank you. Right, so this was my thought process regarding the first question is already answered, surgery versus TAVI. So especially it's a large annuli. Now in large annuli, we know that the only valves which are available presently are balloon expandable, Sapien, Sapien 3, Sapien Ultra, MyValve Gen 1 and Octocore, and self-expanding you have RProbe and FX. So only 2 platforms are available, so you'll have to select in between these 2. Regarding, now, of course, rest of all the points are soft, but regarding the coronary access later on, regarding short membranous septum, regarding probably type 0 with anteroposterior orientation, in which I think it is going to be a difficult crossing with wire, balloon, and THV, I would slightly lean more towards balloon expandable valve. And since it is bicuspid, I don't really want to oversize it too much. Then I would respect the anatomy more, and probably I would go with the intermediate sizing of my valve, because it gives me a freedom to use a 27.5, also probably fine tune it to probably 28 or maybe 27 itself if it is not working, and maybe leave few cc's inside if it is sealing at some other level and you think that something ominous is going to happen, either the valve is shifting to only one side or something. So regarding the procedural strategy, I decided that we do need to be good on both the punctures, because don't take the other puncture lightly, because maybe the narrowing higher up was not picked up very clearly, or aortogram to decide what would be the index size. Safari extra small for sure, because we know that in bicuspid type 0, because of the zigzag orientation of the leaflet and then the opening and then the LV cavity, it's best that you take Safari extra small, because it would be difficult to park a Lundquist wire safely, and mostly it would be pointing downwards rather than upwards sometimes if it is horizontal. Pre-dilatation aggressive for sure, at least 23, but this 23 is also matching my minimum, so I think it's fine. THV sizing 27.5 nominal, because I'm looking at 0 to 5% of oversizing in a bicuspid type 0 valve. High deployment for sure, because one, in view of short membranous septum, and as we already discussed, the leaflets are really tall. I want to seal the leaflets from the top. I don't want any milking down of the valve. At the same time, I don't want any leaflet overhang. Also a bailout plan for peripheral access. If something goes wrong, we should have a clear bailout plan. So that was the strategy. I started from the right femoral access because I thought that the left would be my, the left one. This is the left one. I mislabeled it. And I decided to take a aortogram, or at least have an idea, and you can see clearly the infrarenal abdominal, if infrarenal vessel is not good on the right side. So since my puncture was all good on the left side, I switched to the left side as a main axis, and because both the sides were diseased, I also put a safety wire just to be sure. If something goes wrong, then my bailout procedures become easier. Introduce the Python sheet. This is the aortogram, and you can see these leaflets. They are so tall. They are more than at least. Also, when you scroll the trementio up, you could clearly see that they would rise up to at least 18 millimeters or so. So you're looking at placing the valve really high, because the frame of 27.5 would be something like 19 point something. So you are probably looking at 1 millimeter lower down. And while deployment, again, try to put the top, matching the top so that you cover everything. This is how the Safari wire goes in. Because it was not a very horizontal aorta, it went well, and it is still pointing upwards rather than downwards. And this was the predel. Of course, we know that the calcium was not bad, and we could see that both the sides went symmetrically on both the sides rather than asymmetric expansion, so that was also okay. And this is a 23, not very aggressive. You can now also see the wire shifting to the opposite side. This is how I place the valve, just trying to make sure that the top of calcium of the leaflet is just matching, or my valve is slightly above that. Of course, there's some parallax, but if I change the angle, then probably at least I would be more comfortable with bicuspid type 0 like this. It's a coplanar view, and this is how the expansion went on, and it expanded symmetrically on both the sides, and this was a 27.5 valve. You can, and this is how it looks like, and you could see that probably the sealing also has happened at the annulus or slightly above annulus, because the minimum intercommissural distance, if you measure, was more than 27. And the RCA graft, of course, is flowing well. There's no AI, there's no PVL. And this is post-deployment, just to be sure that there is no AI. And you can see that the valve is almost hugging the aortic borders. So hemodynamic-wise, there was no significant gradient, good diastolic separation, no significant gradient on echo, AR, and PVL. Also, typically, while inflation, I keep my eyes on both the border of the aorta, and if I feel that the valve is moving out in any way, I would probably stop, because I know that it is already anchored. And this is the left CFA angiogram, post-vascular closure, without any problems. And thank you.